Hi everyone, my name is Vincenzo Berghella. Once again, welcome to another sessions of live at AJOG MFM. It's my pleasure to have this special session on novel ultrasound use in labor and delivery. This is the special issue on ultrasound in labor and delivery, led by guest editor Tullio Ghi. Tullio, why don't you take it away? It's so excited to have you and your friends and great colleagues from around the world to talk about this exciting topic. Tullio, please.
Thanks, Vince. It is a pleasure for me to start this event. We have a very distinguished list of speakers, so I don't want to waste more time. We will start with a list of presentation from all the speakers for about 30 minutes. Then we will have an interactive discussion with the audience, so just stay connected. We will start with a presentation by Professor Rasha Kamer, the usefulness of ultrasound before induction of labor. Please, Rasha.
Good afternoon, everybody. Good afternoon from Cairo. I'm a professor in Cairo University. I'm going to give a brief overview of our article in the referred to edition. It was about usefulness of ultrasound before induction of labor. We can use ultrasound in the management of induction of labor by using it to assess the eligibility of a woman for induction of labor. We can use it for the pregnancy dating. We can use it to exclude fetal malpresentations, placenta previa and vasa previa, to assess the fetal well-being, and of course to verify the fetal viability. Also, in cases with prior cesarean delivery, we can use the ultrasound to measure the lower uterine segment myometrial thickness, which was found to correlate with the risk of uterine rupture during labor. For the induction of labor, to try to predict the success of induction of labor, several parameters have been proposed. Cervical assessment was found to accurately predict the induction to delivery interval and the outcome of induction of labor within 24 hours. And we use transvaginal ultrasound to assess the cervix. We can measure the cervical length as a straight line between the two ora of the cervix, or we can measure the posterior cervical angle as the angle between a line along the cervical canal and a line dropped tangential to the posterior uterine wall. Also, assessing the fetal head position was found to be predictive and was incorporated in several predictive models for the success of induction of labor. We slide the transducer across the maternal abdomen until we reach the fetal head, and by visualizing the orbits and the fetal cerebellum, we can accurately locate where the occiput is. Also, we can use transperineal ultrasound for assessing the fetal head position. We can measure the angle of progression, which is the angle between a line going through the symphysis pubis and another line dropped from the symphysis pubis tangential to the fetal skull. This is done by a vertical application of the probe to the perineum of the woman. And the angle of progression was found to be a significant independent predictor for the success of induction of labor, particularly in a laparoscopy. Also transperineally, but with a horizontal application of the probe, we measure the head to perineum distance as the shortest distance between the perineum and the fetal skull. And this was found to be predictive of vaginal delivery after induction of labor, with a predictive value comparable to ultrasound measured cervical length and Bishop score. Also, we can measure the pelvic floor dimensions by, again, transperineal ultrasound, regular 2D ultrasound in the mid-sagittal plane. We measure the distance between the symphysis pubis and the puborectalis. This is the plane of minimal elevated dimensions. Or if we have a 3D and we get the axial plane of the acquired volume, we can measure it as well as two perpendicular diameters or as a trace. And the pelvic floor dimensions was found to correlate with labor outcome, mainly the duration of the second stage of labor. We can also use ultrasound for pelvimetry. We can measure the subpubic arch angle by applying the probe transperineally horizontally at the level of the clitoris, and the angle is the angle between the two converging lines across the two pubic rami. And the subpubic arch angle was found to identify women who are at high risk of operative vaginal delivery, and it correlates with the persistence of different occiput positions. A recently introduced parameter also as for pelvimetry is the obstetric conjugate, where we apply the transducer to the maternal symphysis pubis to visualize the interpubic disc, and we measure the distance between this point to the sacral promontory, which is the most protruding point posteriorly behind the fetal head. This is the obstetric conjugate and is another form of pelvimetry. A lot of these ultrasound parameters were included with various clinical parameters in several models and calculators for the prediction of successive induction of labor. They have been validated with varying results. It helps with the choice going ahead with the induction of labor, or also with the timing of induction of labor. Maybe if it's not favorable now, we can postpone it. So in conclusion, ultrasound has been extensively explored as a reliable and reproducible tool in the management of labor, and lots of studies have explored it to predict and improve induction of labor outcome, considering the potential risks and lack of cost effectiveness in cases of failure, also considering the high rate of induction of labor nowadays. So we recommend that, owing to the promising results of these studies, a comprehensive ultrasound assessment might be beneficial prior to induction of labor. Thank you.
Thanks, Rasha. Thanks for your nice presentation. I give the word now to Andrea Dall'Asta from Parma. He will deal with an interesting topic, the prelaboral intrapartum Doppler ultrasound to predict fetal compromise. Please, Andrea, go on.
Thanks, Tullio, and thanks all for your kind invitation, and good morning, good afternoon, or good evening, wherever you are. I will be going through this issue of prelaboral intrapartum Doppler ultrasound, seeing which is the potential of this technique close to or during labor. I think you all know that intrapartum hypoxia is among the leading causes of adverse neonatal outcome, including death and cerebral palsy, and this can be due to the fact that uterine contractions featuring human labor intermittently reduce the perfusion of the fetal-placental unit. Of course, some cases are at more risk of placental insufficiency and to negatively impacted by uterine contractions. However, looking at available data, we know that the majority of hypoxic complications of labor occur in pregnancies considered at low risk of complications. So this means that the current strategies to identify women at risk for intrapartum hypoxic complications is suboptimal. Which could be the rationale of Doppler? Well, actually, you all know that Doppler ultrasonography is a functional test for the fetal-placental unit, and also that women during their pregnancy are routinely assessed in early labor or close to labor as part of routinely daycare assessments at term pregnancy. Looking at available data, we know that Doppler parameters have been associated with adverse perinatal outcomes and adverse labor outcomes. In particular, this abnormally reduced CPR has been associated with the highest sensitivity for adverse perinatal outcomes. This is the state of the art of the predictive role of reduced CPR for intrapartum fetal compromise when measured pre-labor or intrapartum. There are at least 5 large prospective studies. For a prospective one is retrospective. You can see that the area under the curve is not excellent, and looking at the sensitivity, we know that approximately with Doppler, with an abnormal CPR, we can identify approximately 2 to 3 out of 10 babies that will be delivered by cesarean section or ventouses due to suspect intrapartum fetal distress, with a positive predictive value ranging at about 20 to 30%. This is the best we have, but if you think at the potential perspectives of this technique, you can understand that Doppler having a short screening to delivery interval, and when performed close to labor or during labor, may have the potential to show the effect of a contraction stress test on the fetal placental unit, so demonstrating those cases with a subclinical placental insufficiency. And in such contexts, Doppler may have a further impact should we demonstrate the availability of treatment for the management of suspected uteroplacental insufficiency. There is a recent phase 2 RCT which demonstrated the usefulness of sildenafil citrate in reducing the incidence of obstetric intervention to suspected intrapartum fetal compromise. And this, of course, if these findings were to be confirmed in further studies, this could lead to a further implementation of Doppler ultrasound close to or during labor. And I thank you very much for your attention.
Thanks, Andrea. Very new and interesting topic. Now we move to the next speaker. Next speech is from Birgit Kars from Norway. She will talk about the role of intrapartum ultrasound in women with the prolonged first stage of labor. Thanks, Brigitte.
Good morning, everybody, and thank you for the kind introduction and the invitation to be here today. I'm going to talk about prolonged first stage of labor, and then the first issue is that we don't have a uniform definition of prolonged first stage of labor because we don't have a uniform definition on the start and the duration of all the labor stages. So everybody has different guidelines, and it is important that all labor wards should have their own guidelines and that they should be used, and labor progress should be monitored. And labor progress can be monitored with clinical examination, but also with ultrasound examination. We can examine fetal head position, fetal head station, and cervical dilatation using a clinical examination and also ultrasound. But we know from other studies that ultrasound is more accurate, has a good reproducibility, and is easy to learn. So it is a good possibility to use this in prolonged first stage of labor. When we look at fetal head position, we know that before labor starts, occiput transverse is the most common position. And in early labor, occiput posterior is also very common. But we also know that a lot of fetuses with prolonged first stage of labor are delivered with cesarean section in an occiput posterior position. And when we also know that most fetuses do actually rotate during the start of the second stage of labor and also during the second stage in total, we know that this has to be used, this knowledge has to be used wisely. These are the ultrasound methods for fetal head station, angle of progression and head perineum distance, like Rasha told you earlier. So I'll talk more about the findings that we have found in different studies. When we have prolonged first stage of labor and we measure the head perineum distance as less than 50 millimeters or an angle progression of more than 110 degrees, we know that there is a very high chance of a vaginal delivery. So this could be used to reassure the woman and the clinician in charge of the delivery that you can continue. We also know that if you use the same cutoff, these women also have a significantly shorter remaining time in labor than other women. In other studies, we also have seen that fetuses delivered with spontaneous delivery have a more accelerated descent during the last 4 hours, and the fetuses with an operative vaginal delivery have a more gradual descent. And when we look at the fetuses delivered with cesarean section, they hardly have any descent at all. So this is important to look at during prolonged first stage. So ultrasound can be used during the first stage of labor to give information about fetal head position and fetal head station, and it's also possible to give us knowledge that has the possibility to improve labor outcome. But we have to use the information wisely because a labor is a dynamic process and things change during labor. Thank you very much.
Thanks, Brigitte. We have now a new, very, very interesting presentation. It's from Alex Jimowski. She will talk about the role of intrapartum ultrasound in the diagnosis of cephalic malposition and malpresentation. Thanks, Alexis.
Thank you. Thank you for having me, and good morning from Providence, Rhode Island. This morning, I'm going to talk about intrapartum ultrasound for the diagnosis of cephalic malpositions and malpresentations. And why I like this topic so much is that it's very practical, reproducible, quick learning curve, great for teaching residents on labor and delivery, something that we can use every day to help management of women during labor. And as we know, malpresentation is really in regards to the flexion and extension of the head. And malposition really refers to, for cephalic positions, anything that's not OA. So we're mostly talking about occiput posterior and occiput transverse positions. And this is extremely important because malposition and malpresentations are highly correlated to adverse outcomes such as cesarean and failure of operative delivery, neonatal adverse effects as well. So on exam, sometimes our digital exams, which we obviously routinely do, that they can be difficult due to caput and molding. And what we're trying to do here is make that exam more quantitative. And so when we look, for example, at malpresentation and we try to diagnose face or brow presentation, i.e. the more extended positions of the baby's neck. We can do that by using transperineal ultrasound. And one way, for example, to check on whether face presentation is there is by looking at whether facial features can be visualized on transperineal ultrasound, such as the eyes, nose, and lips in the mid-sagittal plane of the presenting part. Similarly, with brow presentation, transperineal ultrasound is effective in identifying where the location of the orbits are. If they're located on the periphery of the mid-sagittal plane, that would give you a clue as to the deflection of the head. More people or more presenters are going to discuss the occipital spine angle in later presentations, but that also is a great way to quantitatively measure the exact flexion, deflection of the head. The more narrow the angle, the more deflex the head is. I apologize, I'm using myself as a explanation of flexion and deflection. Similarly, for malposition, we use anatomic landmarks such as easily identifiable ones, usually on transabdominal ultrasound. And we can relate these landmarks to the useful imagery of a clock. So for example, for checking on occipit posterior, occipit transverse positions, if we look at the spine and its relation to a clock, we'll be able to identify reliably whether or not the occipit is posterior or transverse. So for example, if the spine is up, we're in the 12 o'clock, the 9 to 3 o'clock range on a clock, then we would diagnose occipit anterior. Additionally, if we evaluate other midline structures such as the orbits, the thalamus, the cerebellum, and the CSP, all of these can help identify the malposition. So in this picture here, you see the orbits are up, therefore you can reliably diagnose occipit posterior. In this, on the other slide, you can see that midline structures are transverse, therefore the occipit is transverse. Again, easily reproducible. And then lastly, we can also use ultrasound to help us diagnose asynclitism. Asynclitism can sometimes be very tricky on exam, especially with the more molding of caput and the more further you get into this, for example, the second stage of labor. And if you want to make decisions based on operative delivery or going to cesarean, then these are really important to help manage the patient clinically. So again, anterior versus posterior asynclitism is all about deflection of the midline structures, and these can be identified with such things like the squint sign. If you only see one eye or one orbit anterior or posteriorly, then that can help you diagnose anterior or posterior asynclitism, as long as other signs referred to as the north or south thalamus sunset sign or north or south cerebellum sunset sign. These are defined as when midline structures are above, north, or below, south of the 3 o'clock to 9 o'clock range. If they're north of that line, then that is referring to anterior asynclitism. Similarly, asymmetric profile sign is how we can diagnose lateral asynclitism. You would expect that the midline structures are easily seen midline in the sagittal plane. If the profile is not looking as it normally appears, then that is a clue to lateral asynclitism. So in summary, you should consider intrapartum and transperineal ultrasound for identification of fetal malpresentation and malposition during labor. They can be a useful adjunct to exam. Most of these can be very easily diagnosed by looking at the orbits especially, and then other midline structures. Malposition is most simply looked again by looking at the orbits, face, and chin to chest angle, which I'm sure other presenters will mention later on. And then asynclitism can be identified by evaluating asymmetry of midline and intracranial structures. So this can help us improve our labor and delivery management and decision-making for women during labor. Thank you.
Thanks very much, Alexis. It's a pleasure now to introduce the next speaker, Inoon Gilboa from Israel. He will deal with the use of ultrasound in the active second stage of labor. Thanks, Inoon.
Tulio, thank you for the invitation. Okay, do you see the screen now?
Not yet.
Share the screen. Right. And I try to share it. Alexis, do you do it? Okay. Okay, I'll try to share it again.
Yes?
Do you see it now?
Yes, we see.
Okay. So hi from Israel. I'm Inon Gilboa. I'm Director of Ultrasound Unit in the Rabin Medical Center. Thank you for this invitation, Tulio. I will speak on how can we empower the woman and engage her in the delivery. We all know the use of mirrors that were used many years ago. So I will try to convince you why to invest in ultrasound and not in mirrors during the last stages of delivery. Now, we all know that ultrasound, if we have a high resolution screen, the woman can we can give the patient a feeling of control when she sees the movement of the heads when she pushes. And she is also, the patient is also aware of the ability and the factor change her body condition when she does it. And especially during labor, she can indicate the proper direction of pushing of the head when she pushes and during the second stage of labor, and this may improve labor performance. Try to flip for the, okay. So what was the additive value during pushing in the second stage when he started to think about using biofeedback for use it during the second stage of labor? We had two hypotheses. One was the medical hypothesis and the other was the psychological hypothesis. Concerning the medical hypothesis, we thought that it will be a better effective pushing when the woman sees the movement of the head. We thought maybe there will be a reduction in the duration of the second stage of labor. Maybe there will be a reduction in the perineal tears, and maybe we can affect the mode of delivery. The psychology hypothesis was that maybe we can improve maternal and neonatal bonding because we know from previous study that ultrasound during pregnancy increases connectedness of the fetus to the mother. And on the other side of the biofeedback, we know that biofeedback actually increases control, and we know that lack of control during childbirth is associated with increased post-traumatic stress disorder following childbirth. Well, we thought that maybe this will be a protective mechanism against the development of post-traumatic stress. So what do women think about and experience during labor? We know that 40% of the women define childbirth as a traumatic event, 17% suffer from partial post-traumatic stress. Now, 4% of the women suffer from a true post-traumatic stress disorder, which lasts more than 1 month. We can intervene after the stress, but if you use ultrasound, maybe we can intervene during childbirth. Maybe we can make a prevention strategy by using the ultrasound. So this was published in 2018 in collaboration with the Reichman University, with psychologists in this institute. This was a prospective observational study. We used visual feedback in 26 patients with a control of 69. All were nulliparous. We used epidural anesthesia, all we're using, and the second stage of labor, we did the intervention. Well, we analyzed the pushing efficacy by using the delta angle of progression, and we saw that when women saw in this group saw the biofeedback, they had a better pushing efficacy when if we look at the control. Additionally, the perineal tears were much more common in the control. Well, we didn't see any effect on mode of delivery and the second stage duration. And on the psychology outcome, we have seen that sense of control was not influenced by the biofeedback. We were surprised, but maternal bonding was actually more common in the biofeedback group. In addition, publication, we saw that the biofeedback had an indirect effect on post-traumatic stress by the mediation of the maternal bonding and acute stress symptoms. Well, Beluzzi has published RCT in the same journal. They use RCT 20 women in each arm. They use sonography coaching, and when the patient were exposed and or blinded to the screen. Well, they used coaching for 20 minutes, and they saw that the duration of the second stage were decreased in the coaching group. The angle of progression delta, as we found out that the delta of the angle of progression, meaning the pushing efficacy, was much better in the biofeedback group. Well, they didn't show any effect on mode of delivery, the perineal trauma, nor neonatal outcome. So what are the benefits of the sonographic coaching of labor using biofeedback? Well, we saw that it involves the woman in the process of their labor. It is important information for the clinician during pushing, as you see the fetal head moving in directions, and you see that the head is the best pelvimeter for assessing the outcome of labor. It may improve obstetric outcomes. This should be checked on a larger scale of examinations, and improve maternal satisfaction, and may influence the post-traumatic stress following childbirth. Thank you very much.
Thanks, Inon. Now we move to one of the most critical issues of obstetrics. Dr. Viola Chan from Hong Kong, she will talk about the use of ultrasound in the choice between instrumental vaginal delivery and cesarean. Thanks, Viola.
Thanks, Tullio, for your kind introduction. So the topic I'm presenting today is whether intrapartum ultrasound can help clinicians to choose between assisted vaginal birth or cesarean birth. And this expert review was written with my senior, Dr. Lau Wai Lam. So I'm sure most of us have performed a vaginal examination at second stage of labor. It's not easy. To me, it's like putting my hand in a magician's hat to try to take out a rabbit, but a teddy bear comes out. So sometimes you thought that the fetal head is in a good position, in OA position, is low, but it turned out to be high and in OP position, which is associated with high chance of failed instrumental delivery. Studies have shown that there's a 30 to 34% error in classification of high, mid-pelvis, low or outlet delivery, regardless of the clinician's experience. To me, I think to most of us, accurate assessment of the fetal head position is especially important during instrumental delivery, because you have to be very sure about the fetal position so that you can put the instrument on the right spot. Because the vaginal examination is inaccurate, clinicians try to find ways to improve the diagnostic accuracy. ISHA has issued a guideline in 2018 and recommends checking the fetal head position and station by ultrasound before considering instrumental delivery. With ultrasound, we can, I think some of the emojis are lost. So anyway, we can visualize the fetal head position, any asynclitism, and the head station, and we can also see the direction of the head movement, and also the extent of the head descent during pushing. Different groups have suggested different values to predict successful instrumental delivery. However, there's no single cutoff that has been agreed on. So this table summarizes the different values suggested by different groups. So in general, you can see that an angle of more than 135 to 138 at uterine relaxation was associated with easy instrumental delivery, while an angle of less than 145 to 153 was associated with difficult instrumental delivery. For the head perineal distance, some studies have shown that if the head perineal distance is less than 25 millimeters or less than 45 millimeters, that would be an easy instrumental delivery. However, if it's higher, for example, more than 40, 35, 55, then there's a high chance of difficult instrumental or cesarean delivery. And some authors also look at the change in the angle and the HPD, and this change actually reflects the extent of the fetal head descent. So our group has suggested that more than 15 degrees of change in AOP is associated with a successful instrumental delivery. for HPD, if the head is not moving or if it's negative, that means that the head is moving upwards, then it's also associated with a difficult instrumental delivery. So, in view of this one, we have looked at all the data, and we want to propose an algorithm model using a concept of traffic light. So in this model, we look at both the clinical parameters and the sonographic parameters, and we categorize the parameters into unfavorable and favorable parameters. If the woman has more than 2 or more unfavorable parameters, then she will be classified as high risk, the red group, that she has a high risk of failed instrumental delivery. If she has 2 or more favorable factors, then it's likely that she'll have a successful instrumental vaginal delivery. So this triage is actually for clinical use, so that the junior can discuss with the senior, and also I think it's a step before they can before they proceed to instrumental delivery. So the take-home message is, when you are considering instrumental delivery, do both vaginal and ultrasound examination to confirm the fetal head position and station, and also to see if there are unfavorable or favorable factors. If there are unfavorable factors, talk to your senior before your final decision. Thank you.
Thank you very much. Now my question to Wolfgang Erich, my friend. How ultrasound can help in the management of postpartum hemorrhage, Wolfgang?
Ladies and gentlemen, thank you very much. Vincenzo, can you start my presentation because I already sent it? Vincenzo, are you on?
Vincenzo?
Vincenzo? Where's Vincenzo?
I don't know.
So
Can you play this?
So I had to kick somebody off. No, we don't have your. We have your screen, Wolfgang. You uploaded your screen, so I can show your screen. I can show this, and now the screen is gone.
Now you should see my screen.
Not yet.
No, should be at the bottom. We had it before. We had your screen.
Shall we?
Here we go. So I can add this, and then you can work to your screen and show your screen, Wolfgang.
Can you open the presentation?
No, you have to do it because it's your screen. Yeah.
Can you see it now?
Yeah. Perfect.
Oh, perfect. Okay. So again, thank you very much to give me the opportunity to talk about postpartum ultrasound and the role of postpartum ultrasound to distinguish between different sources of bleeding. You know that 4% of women bleed 1 liter or more. And so I would like to encourage, especially our young trainees, to get familiar with the typical images of a spontaneous delivery of a placenta, as you can see here in these 2 clips, and to get familiar with the normal, regular shape of the uterus after a spontaneous delivery, and to get familiar with the picture of an empty uterine cavity. Since we are familiar with these images, we are performing ultrasound-guided manual removals under as well as when we have to remove products of conception with instruments. We are performing these under ultrasound guidance, and since this time we haven't seen any perforation or further complications or that we left remnants in the uterine cavity. So another example of the use of ultrasound in the postpartum period is, for instance, in cases with the VBAC, vaginal birth after C-sections. They have a rate of approximately 0.3 to 0.8% of uterine ruptures. And sometimes these patients do not bleed outside, they bleed inside. And so we implement in our routine protocol in cases with vaginal birth after C-section that we perform an ultrasound afterwards to look at the shape of the uterus and to rule out free fluid or clots in the abdomen, as you can see here in this case. And in this case, the rupture site was in the fundal area, which was proven then in a CT as well. The laparotomy revealed the rupture site, and then we repaired the uterus immediately to reduce the complications. So a typical late use of ultrasound in the postpartum period is to diagnose retained products of conception. Here in the case 2 weeks after spontaneous delivery, you can easily evaluate here and see the hyperechoic placental remnants, so with a positive color flow in the structure. So again, under ultrasound guidance, we perform an instrumental evacuation and we document the empty uterine cavity. These are typical clots here, which need not to be removed actually. So a very serious and dangerous source of postpartum or even in pregnancy can these pseudoaneurysms develop. Is this case. Here you can see a pseudoaneurysm of the uterine artery, and it is possible to treat these patients with interventional radiology, with embolization, and it's absolutely contraindicated to perform here in such cases evacuation or instrumental evacuation. So here you can see the result after the interventional radiological embolization. So this was just a last case here. Another cause of postpartum bleeding demonstrated here an AV malformations fed from the left uterine artery, continuous bleeding occurred 4 weeks postpartum. There were no remnants and no products of conception in the uterine cavity, and the DNC makes absolutely no sense and would make complications, unnecessary complications. So again, here the embolization is the treatment of choice, and you can visualize after the embolization the reduction of blood flow in the myometrium. So to summarize, and the reason that I showed you only more or less a pictorial essay about postpartum, the use of postpartum ultrasound, is that there is a huge lack of publications and literature about this topic. However, I think it's a very important tool to use and to distinguish between the possible sources of the bleeding. And again, here the most common might be the retained products of conception in the uterine cavity, here in a case after a C-section, or to visualize the hematoperitoneum after uterine rupture. You have to distinguish between these cystic structures with varying color flow as a uterine artery pseudoaneurysm, and the hypoechoic space with mosaic pattern in the myometrium leads you to the correct diagnosis of AV malformation. So I would like to encourage you to get familiar with the normal findings, and then you will detect in cases of bleeding patients immediately the right diagnosis. Thank you very much for your attention.
Thanks, Wolfgang. Oh, we have learned that in the last few years, the anal sphincter injuries are gaining attention. Maybe they were overlooked for so many years. So maybe this is due to the introduction of ultrasound. Federica, can you just cover this issue? Thank you.
Thank you. Thank you for having me here speaking about this interesting topic. So, postpartum ultrasound for the diagnosis of oasis. Oasis are third and fourth degree perineal tears. And I think we knew that these were kind of rare complication of vaginal birth. But actually, since we are started using ultrasound for the diagnosis of these tears, we know that the vast majority of third and fourth degree perineal tears are actually occult, meaning not recognized in labor room. If you see this table, I selected some literature about the prevalence of sonographically diagnosed and clinically relevant third and fourth degree tears. And as you can see, the prevalence varies between 12 and 35% of vaginal deliveries. And we know that ultrasound improves the diagnosis. Actually, endoanal ultrasound is the gold standard in the diagnosis of these tears. And four-dimensional transperineal ultrasound has been proposed and demonstrated as to be as accurate as three-dimensional endoanal ultrasound in this diagnosis. And most importantly, when we diagnose these tears with ultrasound, these are correlated with the clinical symptoms of anal incontinence. That is much more common than we thought. For both the techniques, we need to obtain many slices of the anal sphincter. In example, with the transperineal ultrasound, we use the TUI technique, that is a sort of sonographic CAT scan. And these are the criteria. So using endoanal ultrasound, again, the gold standard, if you have a defect of more than 30 degrees of the external sphincter in 2 out of 3 slices or more, there is a clinically relevant tear. While using transperineal ultrasound, if you have a defect of more than 30 degrees or similar in more of 4 out of 6 TUI slices, you are dealing with a clinically relevant tear. And this ultrasound, the transperineal ultrasound, can be done at least 10 to 12 weeks after vaginal birth. So our suggestion at the end of this review are to focus on the high-risk patients. We know that forceps is one of the most important risk factors for these complications. So we should avoid forceps as much as we can. And if we want to reduce the risk of oasis, then we were supposed to do rectal examination after vaginal delivery, after all vaginal deliveries, even those we think are less with less severe tears, like even with intact perineum, because we can have a rectal tear even in a apparently intact perineum. And then we can suggest to do 4-dimensional transperineal ultrasound or the gold standard 3-dimensional endoanal ultrasound at 10 to 12 weeks after vaginal delivery for the patient who are at higher risk for this complication. Those with maternal age more than 35, forceps delivery, prolonged second stage, primary oasis repair, shoulder dystocia, and macrosomia. Thanks for your attention.
Thanks, Fede. Now, last but not least, my friend Ali, chef from Bologna. This is a very important area of clinical practice and research, how ultrasound of the pelvic floor may impact on the outcome of labor. Ali.
Carissima. Hello.
There are some echo. Ali? Ali, we cannot hear you well. Okay.
No.
There is some echo. Sorry. Can you use your headphones? Try again.
Can you hear me?
You are muted again. Try again. There is some lag. I don't know. Our director of work, Vincenzo, can you do something? Yes, we can hear you, but the quality of sound is not.
I think there are multiple things open. Ali, maybe you wanna go away, come back in a new session. Kick yourself out and come back with. I'll kick him out and then he can come back. Maybe you can start the discussion, Tullio, and I'll.
Yes, there are so many interesting things. I'm really. It's difficult for me to find something to start from, but I will start just following an order. First of all, I would like to ask Rasha, for example, if a patient comes to you and she wants to be induced. Okay, Ali is back here. Let's try.
Can you hear me now?
Yes, it's fine.
Wonderful.
That's good.
Okay, I'm sorry for that. So, can you see my screen now?
Yes.
Wonderful. So, thank you so much for this invitation with dear friends and big researchers. And my talk will be about a slightly different subtopic in intrapartum ultrasound, which is the impact of the maternal pelvic floor on labor outcome. We are all familiar with the effect of labor on the pelvic floor, but the effect of the pelvic floor and the function of the pelvic floor on labor outcome is less studied. So it's the pelvic floor should be distended and relaxed, especially in the second stage of labor with maternal pushing, to create space for the fetal head. Okay. And there are already many studies that have evaluated the role of pelvic floor on the labor outcome. So we summarized in our article the studies that are available till now on the role of pelvic floor on labor. There is the anteroposterior diameter of the levator hiatus. So the hiatus included inside the levator ani muscle can be simply measured on two-dimensional ultrasound in the mid-sagittal view between the lowermost part of the symphysis pubis and the anterior most part of the levator ani muscle, which is the hyperechogenic structure passing behind the rectum. So this is the anteroposterior diameter of the levator hiatus. It can be measured by two-dimensional ultrasound. It can also be measured by three-dimensional ultrasound, which has the advantage of measuring the transverse diameter of the levator hiatus and the levator hiatal area. And there are already some studies that has demonstrated that smaller hiatal dimensions are associated with a higher risk of instrumental delivery and a higher risk of cesarean delivery, although not all studies has confirmed this association. But definitely the most demonstrated association in the literature is between smaller hiatal dimensions and a longer second stage of labor. So the smaller the diameters of the levator hiatus, both at rest and at maternal pushing, the longer the woman needs to push in the second stage of labor. Another aspect, functional aspect of the pelvic floor. So when a woman pushes adequately, like in the left slide, the left video, the clip, even before the onset of labor, if the distance between the symphysis pubis and the anorectal angle should increase, this reflects an adequate increase in the intra-abdominal pressure combined with a relaxation of the pelvic floor. Whereas on the right-hand side, we can see a woman that pushes, so she's increasing the intra-abdominal pressure. The fetal head is going towards the transducer, but the levator ani muscle is moving to the left, so reducing the anteroposterior diameter of the levator hiatus. This phenomenon is called levator ani coactivation with maternal pushing. It has been associated with a prolonged second stage of labor in nulliparous women at term. So this was a summary of the association between the pelvic floor function and dimension that we know to date and labor outcome. And thanks so much for your attention.
Thanks, Ali. This has been great. So we can start our discussion. So we start with a very burning question to everyone, but of course you can participate. So Rasha, if a patient comes to you and she wants to know a chance of having a successful induction. Which is the parameter among those you have mentioned that you would rely more on? And a second thing that I want to ask you, do you think that the softness of the cervix by means of elastography or sliding sign may have a role also in prediction of success of induction?
It has been explored, cervical elastography, but not with clinical outcome of induction of labor. This is why I didn't touch on that point, and of course also for the shortness of the time allowed. I would begin definitely with, I would do all the composite measurements that I've mentioned. They all have been explored. There's lots of studies studying them all with the different outcomes of induction of labor, whether duration, whether operative vaginal delivery or cesarean section or successful vaginal delivery, and they all have been proven to be reliable. So I would do them all. They're not difficult to do. They're not time consuming. Ultrasound is there. It's not expensive. It's available everywhere. So I would do them all actually. Cervical length definitely is very, very reliable. And as I said, the cervical elastography still has to be explored more in depth.
Thanks, Rasha. Andrea, what do you think this very interesting idea of using Doppler as a triage for a woman coming into labor? Do you think that this can be a sort of tool to decide for which woman it should be considered a continuous monitoring rather than, for example, an intermittent surveillance? Do you think that this can be a useful triage tool for a patient coming into labor, or do you think that the data are too preliminary to conclude this? What do you think?
Thank you, Tullio, for your question. It was actually the main purpose of the study which we ran together. Well, actually, I believe there is a big potential because, to date, the triage of the uteroplacental insufficiency with ultrasound is only on the fetal size, basically. Doppler is maybe very important because you can perform it at the bed of the patient when laboring or when inducing the patient. You can evaluate the residual function. It's not invasive, of course. And so I believe that Doppler, even if, and the overall performance is not dissimilar from that of fetal biometry performed in the third trimester for defining fetal smallness. So my answer is yes, I think there is the potential of the technique. Maybe more data are warranted, and also more data on the potential we have, not only to discriminate between women who may benefit from intermittent auscultation rather than continuous monitoring, but also when identifying women with the abnormal Doppler to treat them. This would be another option.
Thank you, Andrea. I have now a question that is quite transversal because many of the people here of this group have touched this point. So this is a question that I would like to address to Brigitte and to Alexis and Federica and Andrea. Well, the matter is that when we are dealing with a patient with a prolonged or protracted active phase of labor, prolonged first stage, of course, it is very important, as Brigitte has said, to assess the fetal head station at ultrasound. But as some studies have recently demonstrated, and there is a study from Federica a few years ago, and Andrea has done this contribution, and Alexis also has written a chapter on that. We have learned that also the fetal attitude has an important role in that. So to assess if the fetal head is well flexed or is deflexed, this is maybe the first cardinal movement that is so crucial for the fetal head descent. So just in a few words, Brigitte, do you think that we should measure the fetal head flexion when we have a protracted phase of labor? And for example, we should try to quantify, as Alexis has proposed, the fetal head flexion, or we should just rely on a qualitative assessment? Just let me have your idea. I would like to hear your voice, Alexis' voice, and also Federica, that has done a fantastic review on this topic a few years ago.
Well, of course, that's very important. It is you need to evaluate the fetal head station and position, but of course the flexion or deflection of the head is crucial, because otherwise labor won't progress. What we have started with in our department is, when we have a prolonged first stage of labor, we have a timeout. So a more experienced clinician is entering the room and we do an examination. And it is what we have started with, first of all, is just to look if the head is flexed or deflexed. We haven't yet started with more a qualitative measurement of the degree of flexion yet, but of course it is very important, and I would really like to hear what the others has to say about this topic.
Alexis, what's your opinion on that?
I mean, this is a great question, maybe the ultimate question, but you know, when we treat individuals, I think so many things go into account of why their second stage might be going off track. And like Brigitte mentioned before, we don't even agree internationally or even nationally on what is prolonged. So, you know, we have to look at how big is the baby, what's the size of the baby, the parity of the woman, etc. If vacuum or forceps or C-section is even available. I typically look most likely at the flexion or extension of the head if I'm deciding whether or not, like Viola talked about, the important decision of whether to proceed with operative vaginal delivery, keep pushing, or C-section. And I do use this to kind of help me guide decision-making and to help engage the patient in decision-making. So I think it is an extremely useful tool, especially with people learning how to manage normal or abnormal labor, in order to give feedback not only to the patient, but also to people who are training in OBGYN in order to kind of evaluate how is your decision making. But clearly this is I think it's a super exciting topic and needs to be researched more. How does the knowledge of this influence our decision making? Does it inadvertently cause more operative deliveries when it should be, when we want it to avoid it? I don't know. So I think we have to be careful of that and thoughtfully design studies in order to help us figure out how to best use this in the future. But I think it's really interesting that Brigitte is mentioning a timeout. That's something I would love to implement where I am. I think, you know, the second stage of labor is the most critical time in somebody's labor. And I think, you know, getting everybody on the same page is critical.
But Federica, should we follow the philosophy of Galileo's? So to measure or just to assess qualitatively if the fetal head is deflexed or flexed? Because this is something, especially for the OP fetuses, there are actually now the idea from some group, for example, we have done work on that suggests to try to quantify the fetal head deflection, while you have suggested just to look at the attitude of the fetus, and then based on that to try to figure out the fetus as a good attitude and good flexion or not. What's your idea on that? You are muted. Unmute your microphone. Yeah.
Can you hear me now?
Yeah.
Thank you. Great question. So my answer is, I don't know, meaning that I think that flexion and deflection is a very interesting topic. You know that, and that I love these issues. And I think that it makes a huge difference. I don't know if you guys have looked at our StreamYard 2 weeks ago about manual rotation. And even in manual rotation on a large meta-analysis, when we looked at the population of fetuses with good proper flexion, for these manual rotation worked, while for non-properly flexed fetuses it didn't work. So I think we should more focus our research on this, on the impact of flexion and deflection on labor outcome. And if the question is, should we measure or should we just do a qualitative assessment? I think we don't have the answer right now, and we should study it more, do more studies about it. And I think that it's important to focus on it for now. Like coming back to my topic, anal sphincter injuries, as well. So we should focus on it now and do what we are most comfortable with. And then we see if with further research we can clarify these questions.
Thanks, Fede. I have a question from Wolfgang and Viola. I would like to engage both of you now, because Wolfgang has been one of the pioneers in predicting at ultrasound the outcome of operative vaginal delivery, and his idea was extremely simple and efficacious. Just look at the fetal head direction. If the head is going up, this is a good sign. While Viola has proposed some very useful and quoted sonographic measurement of the station. So I would like to hear your opinion, your different opinion. Please, I will start from Viola. Which are your idea about measuring the HPD and the angle of progression? And then I would like that Wolfgang, that is one of the proponents of a qualitative quick assessment, will give his opinion on that. Thank you.
I think it's actually because in our center we've been doing the intrapartum ultrasound for more than 10 years. I find that it's a quick procedure to do an ultrasound before considering the instrumental delivery, and always turn the screen to the woman, because as you all know that you need the woman to cooperate with you when she push, and then we can pull at the same time. And the algorithm model that we propose is actually a collective wisdom from everyone here, because because there's actually no agreed cutoff. So what we can do, or what our experience is that if the head is low, then the AOP is wide, and then the HPD is small. So together with the head direction and the fetal head position, then we can actually quite confident to say that it's going to be an easy procedure. Of course, there will be surprises. So that's why our algorithm didn't say there's a percentage of prediction. It's just in terms of risk. Do I answer your question?
Of that, please.
I absolutely agree with Viola. I think that for me, still, I'm using this before vacuum extraction since 16 years. And for me, it's still the head-up sign, the best predictor, especially when I have a problem with the time and I just see that the head comes from horizontal during pushing upwards, then I'm sure that I will proceed successful. And beside this, for the ones who like to measure, it's very simple. 100 degree is -2, 120 is ±0, and 140 is +2. So 2 centimeters of the leading fetal head is 2 centimeters below the ischias plane. And beside this, you also can do 3D ultrasound, because you can see the sutures and the fontanelles. So this gives you also an impression about the leading point, if the small fontanelle or the anterior, the posterior or the anterior fontanelle is the leading point. So this is another option to immediately to assess the flexion of the fetal head, as we know that the best is if the posterior fontanelle is leading, and then we have an appropriate flexion of the fetal head. So this in combination might be a new idea to evaluate just the suture by 3D. And this is quite easy to detect and possible. So I think the combination of head direction plus the flexion by visualizing the sutures and fontanelle in 3D could be also an easy access to find the right decision.
Thanks, Wolfgang. Let me engage now Inone and Dali, because you are looking at the two faces of the same medal, I think. Inone is saying it's very important to coach the woman thanks to the use of ultrasound during active pushing. in order to allow the woman to push more effectively the fetal head into the birth canal. But Ali is saying, yes, it is important because this may help, but of course a woman must be able to relax a pelvic floor in order to favor the fetal head descent. So I think that the two things should go together. So do you think, Inon, that in your patients, besides teaching on how to push, looking at the screen, is also important to teach on how to relax the pelvic floor? Because if a woman push with the maximum effort, but the pelvic floor is not accommodated for that, this may lead to an effective pushing. And as Birgit has taught us in a paper, you can have, for example, a minus delta of the head perineum distance rather than a short distance during pushing.
This is a very good question, Tullio. We use this pushing when the patient pushes and we see coactivation, as Ali said. We use this before labor. The time it was too short, but we use it before labor in order to assess the prediction of mode of delivery. We tell the woman to push. Many times we see the woman coactivates the levators. So what we do, we tell them to cough. When the patient coughs, then the head goes down without retraction of the levators. And when she sees that, she can start to cough sometime, and then she sees the head goes down, and then she understands how to push and eliminate the coactivation. So we know that coactivation is, it doesn't help for the labor, and we know that you have the bad interaction during delivery when you tell the woman that she is not pushing well. And if you don't have the ultrasound screen, you are going to have confrontation with this woman. If you have the ultrasound screen and she sees that she doesn't push well, and she starts to cough and she starts to eliminate the coactivation, then the head will go down if there is pelvic capacity.
Thanks, Ali. Of course, you have said this is absolutely convincing that for women who coactivate, we expect a longer duration of the second stage and maybe also an increased rate of obstetric intervention. Do you think that this may also go with a higher risk, for example, of pelvic floor trauma and oasis? Because we do not have data on that, but I think that if a woman pushes against a contracted pelvic floor, this may lead to an increased rate of tears, as Federica was telling us. What's your opinion on that?
Well, thank you, Tullio, for the question. I think that the higher the resistance in the soft tissues, whether the connective tissue or the muscles, the higher the risk of having lacerations. Okay, so definitely the collaboration of the woman, the pelvic floor relaxation, okay, can I think that this can be protective against especially levator and eye trauma, and we have found that the Christeller maneuver is associated with a higher risk of levator and eye trauma. We think that the issue that sometimes the Christeller maneuver is done against the collaboration of the woman, so forcing the muscle without the collaboration of the woman can be one of the main factors for this finding. But I have to say that these are, for the time being, are speculations. Okay, so we need data whether the coaching of women should be individualized, so personalized, so each woman may have a package of assistance kit, let's say, that is different from another woman. So we know that not all women with the same physical characteristics do not behave the same in labor. So probably our behavior should not be the same with all women in the labor.
Yes, I fully agree. Wolfgang, don't you think that is a bit bizarre, the fact that your picture is extremely convincing, and in clinical practice, I think that no obstetrician among those who are in charge of the labor wards can do their job without ultrasound when a woman is bleeding. But there is no clear indication from the guidelines on which clinical role should be given to the use of ultrasound in the postpartum hemorrhage. Do you think that this is something that should be somehow amended? Because I think that this is 2022 is a big vacuum of our of a recommendation that should guide our clinical practice. What's your opinion on that?
My opinion is that guidelines are always 15 years behind. And the second thing is that traditional obstetricians are not trained by ultrasound. The new generations need to come into the right positions. And the new generation used to be trained by ultrasound, and they implement, as we do, as our group do, implement the ultrasound on the delivery ward. We need machines, and there are also a lot of clinic hospitals behind that they have no ultrasound machines on the ward. In some countries, ultrasound belongs to the radiologists, which are not obstetricians. So there are several reasons for that, but I think that it is logical that this simple tool, which is now in all the medical fields more and more implemented, that it needs to use it also postpartum. However, again, it will need studies because we all ask for evidence-based medicine. We need studies about this, but also here the problem will be that the number to treat will be relatively high to make at the end differences in the outcome. And I mean, if somebody bleeds 500 or 1,000 or 1,300, depending if the ultrasound was used or not, will make at the end not such a big difference because nobody will die due to this fact. So the problem will be to find the right evidence, and you need a huge number. However, since we can make historical cohorts and actual cohorts, and we saw patients coming back after manual removals which had still some remnants, and we did a DNC again. So however, these patients went healthy home again. But the difference is nowadays that we document, that we make sure that the remnants are all removed. We make a documentation in the chart, and we can really have an evidence that we treated right. So and we haven't seen any complications in that, no perforations, because the ultrasound guidance helps the assistant to be cautious in the uterine cavity in the postpartum period, because it is a difficult situation. The muscle is very soft, and you can perforate and you can harm the patients. But it needs a lot of patients in each huge number to treat, to show by studies differences. And this is what we had also with a study from Murphy, who said that it makes no sense in the neonatal outcome when they do 500 or 300 ultrasounds before vaginal operative deliveries, and they found not the big difference. So this is just a matter of the size and if the people say the truth, what they publish.
Yeah. Federica, just one of the last questions, because we need to wrap up now. Yes, of course, we feel that maybe the Oasis have been sort of the submerged part of the iceberg, and now we are really getting aware of this. But one of the criticism that may arise regarding the use of ultrasound in diagnosing Oasis is that it seems quite tricky and complicated to do a 3D reconstruction, TUI, and whatever. You have published a nice study that gave a very simple method to assess if there was a higher risk of Oasis. Can you just summarize that study in order that people can be encouraged to use ultrasound in doing a sort of quick screening of the possibility of the defects?
Yeah, of course. So we published this data on the Pink Journal, I think in 2020 or 2019. It was a small prospective study, but it's shown that looking at the contraction of the anal sphincter after vaginal delivery and prior to suturing, you actually are able to see properly if there is a good contraction, even in patients with epidural analgesia. And so if you can see this contraction, this sign is associated with a good outcome in terms of anal incontinence and in terms of sonographically diagnosed tears of the anal sphincter when performed after, I think, a 4 months follow-up. Because actually, it's difficult to do a 4-dimensional ultrasound with the TUI technique and so on in labor room. And it is also probably unreliable because of many artifacts that you can have because of the swelling of the tissue after delivery. And so this is something that we can do probably. So we can do it with our fingers as well. So during rectal examination, we often have to ask patient, can you squeeze, and feel the contraction. But with ultrasound, we are more sure about which muscles the patient is using, because you can see with your eyes the contraction. So this is something that we can do. And another issue is also that with ultrasound, there is also some overdiagnosis of 3rd and 4th degree sometimes, because it's even in clinical practice, it's sometimes difficult to distinguish between the transverse perineal muscle and the external anal sphincter. So it's a very interesting topic, and we have to work more on it.
For the next StreamYard, I think. So I would like to call back our host, Vincenzo, that hopefully will close this event. I was so pleased to be part of this fantastic event. Vincenzo, up to you.
Thanks, Tullio. This was a great summary of a huge special issue of ultrasound and labor. So thank Tullio for organizing it. Thanks, Alexis. Thanks, my good friends Ali, Andrea, Rasha, Brigitte. You guys were great. Of course, Federica and Viola, Wolfgang, and from so many parts of the world. It's wonderful to have the opportunity to talk. You guys could have gone for many sessions, and I hope you'll come back soon to talk about ultrasound and labor, because I think it's not the future, it's the present of managing ultrasound and labor. So thank you again, Tullio, and everyone. Have a great day, everyone. Good morning, good afternoon, good night.
Thank you. Bye. 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 Bye.
Bye. Bye all. Thank you.